Liver and gastrointestinal disease in pregnancy. Physiological changes in pregnancy, relaxation of smooth muscle resulting in decreased the sphincter pressure, decreased gastric peristalsis, delayed gastric emptying, increased the small and large bowel transit times, thus leading to gastric reflux and constipation. Alkaline phosphatase rises with gestation due to placental production. Um, ALT and AST and gamma GT are reduced throughout pregnancy. Albumin falls by 20 to 40%, partially by dilutional effect. Fibrinogen, ceruloplasmin, transferrin, and many of specific binding proteins increase. Bilirubin levels do not change in pregnancy. Signs and symptoms: nausea and vomiting, dyspepsia and heartburn, constipation, spider nevi and palmar erythema due to elevated estrogen levels. Common complaints of pregnancy: nausea and vomiting, gastric reflux, constipation, and abdominal pain. In hyperemesis gravidarum, the first pathology, um, it is an intractable vomiting associated with dehydration, ketosis, and electrolyte imbalance, and more than 5% weight loss. The causes is unknown. We have multiple theories behind the pathophysiology of hyperemesis gravidarum. Onset is always in the first trimester. Maternal complications: hyponatremia, hypokalemia, thiamine deficiency leading to vernix encephalopathy, which is a triad of ophthalmoplegia, ataxia, and confusion. Vitamin B12 and B6 deficiency, metabolic hypochloremic alkalosis due to vomiting, Mallory-Weiss tears in the esophagus because of the recurrent vomiting, fetal complications, small for gestational age and growth restriction, and increased risk of preterm delivery. We may have biochemical thyrotoxicosis because the most accepted theory behind hyperemesis gravidarum is increased SCG that mimic the TSH, leading to thyrotoxicosis. Abnormal liver function test can be seen. Complications of electrolyte imbalance can happen rarely, like central pontine myelinolysis. When we correct the hypernatremia in a fast way. Management is always inpatient because the patient cannot tolerate oral antiemetics. Fluid replacement with 0.9 saline. Potassium should be added according to the potassium level. We shouldn't use dextrose because it can exacerbate the vernix encephalopathy and the thiamine deficiency. We may give thiamine supplementation. Thromboprophylaxis is always should be given. Avoid iron formulations because it increases the GI upset. Corticosteroid and ondansetron can be used in severe cases. These are an examples of antiemetics. Constipation: 40% of pregnant women will complain of constipation. Other causes may be found other than pregnancy, like painful perianal conditions, hypothyroidism, hypercalcemia, and some neurological disorders. These are the choices of treatment for the constipation in pregnancy. Gastroesophageal reflux disease needs dietary modification, like spicy and fatty food should be avoided. Avoid food and fluid immediately at bedtime. sleeping on the left side, elevating head of the bed, antacids, H2 receptor blockers, and in some cases we may use omeprazole. Pancreatitis is a rare surgical cause or surgical disease in pregnancy. Symptoms include epigastric pain, nausea, and vomiting. Risk factors: alcohol, hypertriglyceridemia, and primary hyperparathyroidism that leads to hypercalcemia. Investigations: serum amylase usually more than 1,000. Management generally as for non-pregnant women, IV fluid, analgesia, and NPO. This management should be done with a surgeon. Um Peptic ulcer disease, also rare, with a decreased incidence compared with non-pregnant women. Pre-existing disease tends to improve. Prostaglandins and estrogen induced by pregnancy will protect the gastric mucosa from this disease. Symptoms include epigastric pain, coffee ground vomiting, and the presentation may be as a complication like perforation or hemorrhage, which is very, very rare. Management as for non-pregnant ladies, like antacids, um, we may use Helicobacter pylori eradication, but it should be delayed after pregnancy. The most important one is the obstetric cholestasis. It is an intrahepatic cholestasis of pregnancy, multifactorial condition characterized by pruritus in the absence of skin rash with abnormal liver function tests, um, which resolve after birth. These are the characteristics of intrahepatic cholestasis in pregnancy. Less than 1% of pregnancies is affected by obstetric cholestasis, more common in South America. Most commonly present in third trimester between 30 and 32 weeks gestation. Fetal risks associated with obstetric cholestasis: spontaneous and iatrogenic preterm birth and fetal death. Maternal morbidity in association with intense pruritus and sleep deprivation and postpartum hemorrhage. Diagnosis: it is an unexplained pruritus, occurs in pregnancy with abnormal liver function test or and raised bile acids, um, which resolve after delivery. Pruritus that involves the palms and soles are characteristic of this disease. The pruritus of obstetric cholestasis is typically worse at night, is often widespread, and may involve the palms of the hands and the soles of the feet more commonly. Unexplained abnormalities in transaminases, gamma-glutamyl transferase, and all bile salts are considered sufficient to support the diagnosis of obstetric cholestasis. Alkaline phosphatase is not helpful because it is normally elevated in pregnancy. Bilirubin is rarely increased because of obstetric cholestasis. We depend on the transaminases and gamma GT and bile acids. Other evidence of cholestasis should be sought if the picture is suggestive of surgical hyperbilirubinemia, like pale stool and dark urine and jaundice. This is called obstructive jaundice. This most likely to be a surgical cause due to obstruction in the common hepatic duct or common bile duct. We should use a pregnancy-specific references for the liver function test. We said previously that the transaminases normally decreased throughout pregnancy. So in each trimester, we have a specific ranges for the normal liver function test. Um, uh, we should repeat liver function test every 1 to 2 weeks if they appear to be normal in the first time and the symptoms of obstetric cholestasis persist. We should confirm postnatal resolution of pruritus and abnormal liver function test after delivery postnatally to confirm the diagnosis of obstetric cholestasis. Bile acid should be done while fasting for at least 8 hours. Um, we have some cases in which the liver function test is normal but the bile salt is elevated. This is uncommon, but it can happen and it helps in the diagnosis of obstetric cholestasis. Risk factors: personal or family history of obstetric cholestasis, multiple pregnancy, hepatitis C carriers, and presence of gallstones. Monitoring: once we diagnose obstetric cholestasis, it's reasonable to measure liver function test weekly until delivery. We should investigate for other causes of abnormal liver function test like preeclampsia, so we should monitor blood pressure. We do liver function test 10 days after delivery to make sure that the liver function test became normal. We have increased risk of stillbirth and intrauterine fetal demise above the normal population, reaches 1.1%. Obstetricians should be aware and we should alarm the woman about the incidence of premature birth, especially iatrogenic. Why iatrogenic? Because we tend to deliver these patients earlier, making them at risk of iatrogenic preterm birth. Also, the most common finding in pregnancies with obstetric cholestasis is the meconium passage, which may lead to increased risk of fetal distress and intrapartum cesarean delivery. Women with obstetric cholestasis should be booked in under consultant-led, team-based care and give birth in a hospital unit because of the factors that we mentioned before. Poor outcome cannot currently be predicted by biochemical results, and delivery decisions should not be based on results alone. No specific method for monitoring and prediction of fetal death. Not ultrasound, not CTG. These are not reliable in preventing fetal death in obstetric cholestasis. Because of this, we tend to deliver these patients earlier, leading to premature iatrogenic premature delivery or preterm delivery. Continuous fetal monitoring in labor should be offered. So this pregnancy should be dealt with as high-risk pregnancy with continuous monitoring intrapartum. The timing of delivery is very controversial. We don't recommend any delivery before 37 weeks. After 37 weeks, the timing of delivery should be discussed thoroughly with the mother. Treatment: we have no treatment to decrease the risk of intrauterine fetal death. The treatments all are just symptomatic. Topical emollients. Ursodeoxycholic acid is the most or the commonest medication that is used. It improves pruritus and liver function test, but the outcome is not altered. Dexamethasone can be used. Vitamin K should be used in pregnancies with abnormal DIC profile, increased PT and PTT starting from 32 to 34 weeks. We should, as we said, make sure that the liver function test became normal after delivery. It has a very high recurrence rate, something between 50 and 90%. Um, Estrogen-containing contraceptives should be avoided if we diagnose an obstetric cholestasis. This is a summary for the obstetric cholestasis. It's unique to pregnancy, especially third trimester. Incidence not totally known. It's about or less than 1%. More common in, as we said, multiple pregnancy, after IVF treatment, advanced maternal age, women with gallstone or hepatitis C. Symptoms: pruritus of the limbs and trunk, mainly palms and soles, excoriations but no rash. Excoriations because of the itchy, because it's itchy, but we have no skin rash. It's a diagnosis of exclusion associated most of the time with abnormal liver function test and or bile acids. Um, okay, so this is the summary of obstetric cholestasis. Acute fatty liver, we discuss it in the lecture of low platelets in pregnancy.